So today I will be presenting on cannabinoid hyperemesis syndrome. The objectives are listed here, but I'll run through them. The first one is to define cannabinoid hyperemesis syndrome, or CHS, as I'll be referring to it throughout the presentation, and differentiate it from cyclic vomiting syndrome, or CVS. Identify appropriate treatment regimens for CHS. Determine appropriate transitions of care for hospitalized patients being treated for CHS, and understand the current climate of cannabis legalization and criminalization and its implications on public health. We'll start with some background information that I think will be pertinent throughout the rest of the presentation. So let's talk about the background on the status of marijuana in Wisconsin. Currently, THC, a component of cannabis that we'll talk about in depth in coming slides, is a designated Schedule I controlled substance. Cannabis possession for recreational use is illegal currently in Wisconsin. However, CBD, which is another component of cannabis that we'll talk about, in any form is approved for medical use. So knowing that CBD is approved for medical use, it can be used for any medical condition for a patient who has received proper physician recommendations and then obtains a certification from that physician. So when they are in possession of CBD, that certification is no more than a year old from when they are in possession. So to clarify that, if a patient is in possession of medical CBD, they must have a certification from that physician or a physician that is not dated more than 1 year prior to the date of possession. And if any expiration date is provided by the physician, so oftentimes there will be a duration on that certification. When they're in possession of that CBD, we have to make sure that that certification expiration date has not passed. As you can see in this visual, surrounding states of Wisconsin, particularly Illinois and Michigan, do have much more progressive laws and regulations pertaining to cannabis. So I think this is important to note and realize, because that means that forms of cannabis of any kind that's not regulated in Wisconsin has a pretty high chance of crossing the border into Wisconsin. Based on the Center for Behavioral Health Statistics and Quality's National Survey on Drug Use and Health, between 2016 and 2017, tens, if not hundreds of thousands of individuals in Wisconsin reported some type of marijuana use between 2016 and 2017. This is not differentiating between medical versus recreational, just of note. So again, this just goes to show that while there is tighter regulation of marijuana in Wisconsin, the prevalence of marijuana use or cannabis use is still quite high. So as promised, cannabis itself is a plant that produces up to 100 cannabinoids. Two of the main ones that we have often heard about and see are THC, or tetrahydrocannabinol, and CBD, cannabidiol. THC is the strong psychoactive component of cannabis. So think like that's what gives the reported high of using cannabis or marijuana. And CBD is the non-psychoactive component, which is often associated with the pain relief, the antiemetic properties, appetite stimulation, things like that we've heard of for medical use. We'll spend the next few slides learning a little bit more about these components and why they're pertinent to our talk today. But before we do that, I think it's important to dive deeper into how these components act on our body. So I'd like to review two major cannabinoid receptors that CBD and THC work on. Within the body, we have CB1 and CB2 receptors. These are G protein coupled receptors. And so, as noted on this chart, CB1 is primarily located in the CNS, or our central nervous system, and our gastrointestinal tract, or GI tract, with additional receptors all throughout the body, as I have listed here. So the spleen, heart, liver, uterus, and so forth. Activating CB1 receptors mediates most of the psychoactive effects of cannabis and some analgesia. Much less is known about the CB2 receptors. What we do know is that it's primarily found on immune cells and tissues, and activating it leads to anti-inflammatory effects and immunomodulatory effects. So back to THC and CBD. This slide is pretty dense, but includes some pretty important information for us to consider throughout the rest of the presentation. So as mentioned before, THC is primarily the psychoactive component of cannabis. It works as a partial agonist at both the CB1 and 2 receptors. CBD, on the other hand, is the non-psychoactive component and has a lower affinity for CB1 and CB2 receptors. However, it is a partial agonist to the 5-HT1A serotonin receptor. Both CBD and THC have similar pharmacokinetic profiles, with both of them accumulating in body fat. They're both metabolized by the liver and have a half-life somewhere between 20 to 30 hours. This data that I'm presenting is based on population studies with inhaled products. So I want to just make that clear. The values might be different with oral or IV products. So we're focusing mainly on inhaled products throughout this presentation. Additionally, they have quite a few drug interactions that I've listed here. I won't read through all of them, but the main takeaway that I just wanted to get across is that it is important to take a thorough social history so that if a patient is on any type of CBD or THC, that we can assess if any of these interactions exist, and then they can be addressed and accounted for. An additional takeaway that I'll talk more about later on in this presentation, but I just wanted to mention here, is that both CBD and THC are lipophilic in nature. So this might have an implication on CHS, in CHS. So chronic users of cannabis have a larger lipid store, making them more susceptible to increased cannabinoid levels, which could be leading to what we see as CHS. So we'll talk more about this throughout the presentation. In addition to the cannabinoid receptors found in the cannabis plant, 2 major endocannabinoids have been identified as well. So this is anandamide, or AEA, and 2-arachidonylglycerol, which is shortened to 2-AG. These are arachidonic acid derivatives that occur naturally in our body and bind to CB1 and CB2 receptors. So AEA has a high affinity, or is a high affinity partial agonist of CB1, and it has no activity against CB2. And again, just as a reminder, that CB1 is what mediates our psychotropic effects, and then 2-AG is a full agonist at both the CB receptors with low to moderate affinity. Both of these components, or endocannabinoids, interact with various receptors as well. But of note, they do have affinity for the transient receptor potential cation channel subfamily V member 1, or TRPV1, which plays a significant role in pain regulation and is found throughout the GI tract and medullary vomiting center, which is often in proximity to CB1 receptors. So dysregulation of these cannabinoids has been implicated in a wide range of pathologies, including anxiety disorders, neurodegenerative diseases, obesity, and heart disease. So I wanted to include these, not because they're too pertinent to CHS, but because just for completeness sakes, that they do exist within our body and do have implications on various diseases. So let's get into the nitty-gritty of our disease state. CHS was first described in 2004. Hallmark symptoms include cyclic vomiting or cyclic episodes of nausea and vomiting, weight loss, dehydration, and abdominal pain. And it's often characterized by chronic cannabis use, and it's commonly associated with excessive hot bathing or showers, which we'll talk more about. CHS is a recurrent disorder with times of symptom, or intervals, I should say, of symptom-free periods, and resolution symptoms is seen after cessation of cannabis use. So that's the key part that we'll talk about in the coming slides. So generally, CHS affects young adults with a history of chronic marijuana use. And chronic here is defined as use of marijuana for greater than 3 to 5 times a day or more. Typically, we see its onset several years after chronic marijuana use. In the clinical course, a CHS follows the pattern of a prodromal, hyperemetic, and recovery phase, which we'll talk about here on the next slide. So the prodromal phase, that can last from months to years, with patients developing this like early morning nausea, fear of vomiting, and abdominal discomfort. And this is typically when patients begin to use marijuana even more during this time in hopes that it'll relieve their symptoms. The next phase is the hyperemetic phase. So this is what we're going to be focusing on as CHS. It's characterized by incapacitating nausea and vomiting that's persistent. Patients present with significant weight loss, dehydration, but they are hemodynamically stable. And this phase usually lasts about 48 hours. And with treatment that involves things like fluid resuscitation and antiemetics. And then during this phase, you also see patients attempting to self-treat with hot showers. And additionally, during this phase, you also see that when they come to the hospital, they're often misdiagnosed, or there's a delay in diagnosis because of the wide variety of differential diagnoses that present this way. And we'll talk a little bit more about the implications of that. After the hyperemetic phase is passed, we move into recovery, which could last from days to weeks to months. And it really focuses on relative wellness and establishing normal eating patterns to promote weight normalization and bathing returning to regular frequency and cessation support. So how is cannabinoid hyperemesis syndrome, or CHS, diagnosed? It's included in the wide variety of GI disorders that are incorporated into the Rome Foundation criteria. So Rome 4 is the newest public version of the diagnostic criteria. It's a resource that is pretty neat. It addresses organ-based criteria, physiology, pharmacology, psychosocial considerations, and much more to essentially create a comprehensive as comprehensive of a database as possible. Something else that I thought was pretty neat was the Rome Foundation received input from over 100 authors from 23 different countries. So this is really a global resource that's used. So for the Rome criteria, diagnosis of CHS can be made if all of the following are met. The first one, stereotypical episodic vomiting resembling cyclic vomiting, presentation after prolonged cannabis use, and then the relief of vomiting episodes by sustained cannabis cessation. Another note or an indicator that they mentioned, but isn't technically a diagnostic criteria, is the presence of that pathologic bathing behavior. I believe that in order to really understand how to treat CHS, which is what we're all probably here for, it's important to have a quick refresher on the pathophysiology of nausea and vomiting. So both nausea and vomiting can be triggered by various different stimuli, but in general, they're a defense mechanism, right? For when something foreign enters our body. The vomiting center is located in the medulla oblongata. Specifically, it houses the chemoreceptor trigger zone, or the CTZ. And underlying mechanisms of nausea vomiting really stem from the CNS, the GI tract, endocrine system, and are mediated by a variety of neurotransmitters, including serotonin, dopamine, histamine, acetylcholine, that work or often impact our chemotherapy trigger zone. I wanted to mention this because these neurotransmitters and their actions oftentimes help us determine the drug targets for the management of CHS symptoms, because essentially the management of these symptoms is management of nausea and vomiting. So essentially, just one more time, nausea and vomiting is mediated primarily by this visceral stimulation through dopamine and serotonin, by vestibular or central nervous system causes through histamine and acetylcholine, and by the chemoreceptor trigger zone stimulation through mainly dopamine and serotonin. So what about the pathophysiology of CHS? I will say that it's largely unknown, hence the big question mark here. Some theories include that toxic cannabinoid levels may stimulate the CB1 receptors, resulting in delayed gastrointestinal motility and subsequent nausea and vomiting. So if you remember, our CB1 receptors are really located all throughout our body, mainly in the CNS and the GI tract. Or the CB1 central receptors may become downregulated with chronic cannabis use, often resulting in emetic effects, and the anti-emetic effects of low levels of cannabinoids may then be overridden essentially by these pro-emetic effects of the high cannabinoid concentrations. Another theory that's out there is the disruption of the thermoregulatory system caused by CB1 receptor stimulation in the hypothalamus, which may induce this nausea, which leads to vomiting. When talking about CHS, I think it's also important to mention cyclic vomiting syndrome, or CVS, because this is often a diagnosis that patients receive prior to being diagnosed with CHS. So similar to CHS, it's characterized by sudden, repeated episodes of severe nausea and vomiting that can last anywhere from a few hours to several days. And then again, these episodes are followed by symptom-free periods. In contrast to CHS, these symptoms are not suppressed with hot bathing. They're not associated with cannabis use. So those are two main differentiating factors between CVS and CHS. So again, the diagnosis of cyclic vomiting syndrome can be found in the Rome 4 criteria and includes all of the following: the stereotypical episodes of vomiting regarding onset and duration, at least 3 discrete episodes in the prior year, and 2 episodes in the past 6 months occurring at least 1 week apart, and then absence of vomiting between episodes. But other milder symptoms can be present between those cycles. So essentially, that's those symptom-free periods. And then a note that's included for CVS is that many of these patients may have a history or a family history of migraine. So as you can see, the diagnosis of CHS can be very difficult. Failure to recognize that chronic marijuana use, and this can be done, if a proper social history hasn't been taken or if the patient is unwilling to share. This can really lead to misdiagnosis or delays in diagnosis and essentially delays in patient care. And failure to recognize CHS can lead to really increased use of healthcare dollars by running additional tests, hospital readmissions, unnecessary medication use. And this all, we think about it affecting the health system, but it affects the patient even more because oftentimes it's their money that they're using as well to help solve their problem. One case series reported that the average number of emergency room visits prior to the diagnosis of CHS was about 7, and diagnosis was often delayed for years. And that case series mentioned that the longest account from when the patient first started showcasing these symptoms to when they were actually diagnosed with CHS was 9 years. So with that, we'll start with an easy question. Which of the following differentiates CHS from cyclic syndrome? I don't know how to see the chat, but if anybody wants to unmute, well, it's going to be pretty cool.
Shivani, I can let you know what people say in the chat.
Cool, thank you.
Like I'm seeing a lot of C's.
Yeah, perfect. So pretty easy one. The symptoms resolve soon after cannabis cessation in patients with CHS. So again, that's one of those differentiating factors between CHS and CVS is that patients with CHS, again, inherently are chronic marijuana users. So stopping will amount to their symptom resolution. Whereas in CVS, patients are not chronic. They could be, but that's not what's causing their cyclic vomiting. So now that we've discussed the diagnosis of CHS, let's dive into how we treat. The mainstay of treatment includes fluid resuscitation, antiemetics, capsaicin, hot bathing, and arguably most importantly, the abstinence from cannabis. So we'll be focusing on the later 4. As pharmacists, we know that it can be difficult for anyone who's struggling with substance misuse to simply stop using. There are several different options that we can suggest or offer patients who are struggling, and these include the Substance Abuse and Mental Health Services Administration, which is a branch of the U.S. Department of Health and Human Services. It offers this national helpline. I've included some information about it here, but it's a 24/7 program. It's confidential and it functions 365 days of the year. CBT, cognitive behavioral therapy, is an option. Motivation enhancement therapy, contingency management, as well as inpatient or outpatient detoxification programs, just to name a few. There's a meta-analysis of studies out there which involves more than 23,000 individuals, and it found that 47% of participants who use marijuana regularly experience cannabis withdrawal symptoms. So that just shows that, we suggest abstinence from cannabis when patients are diagnosed with CHS, but it takes a lot more than just telling them to stop. So providing that support is crucial for the continuation of and prevention of the CHS symptoms recurring. Antiemetics are another mainstay form of symptom management for CHS. I'll review a few options now, and we'll speak towards the literature, mainly case reports, what they have said later on in the presentation. So first, I'll talk about our tried and true serotonin receptor agonists. Mainly, we see ondansetron or zofran can use. These work by blocking serotonin from interacting with the 5-HT3 receptor, the serotonin receptor, which is involved in information transfer, essentially in the GI tract, and regulates gut motility. For the slides to come, I have listed side effects and drug interactions as well, but we won't review them specifically throughout the presentation, just for in the interest of time. But I did want to mention that none of the medications that I mentioned have a specific indication for CHS, and therefore the dosing listed is extrapolated from case reports of CHS, or is dosing that is listed for moderate to severe nausea and vomiting in adults. It doesn't include any dose adjustments that may be needed based on various indications or renal function. So I just wanted to mention that before we move on. Another option is our benzamide class of medications, specifically metoclopramide, that's often used for undifferentiated nausea and vomiting. It antagonizes the D2 or the dopamine 2 receptors at low doses, and it antagonizes the 5-HT3 receptors at high doses. So I will say the literature shows minimal effectiveness of metoclopramide in CHS. However, we do still see it used quite often in CHS patients, which we'll see in the literature. So I wanted to include it. The next one I wanted to mention is haloperidol or droperidol next. They work on antagonizing the D2 receptors as well and have off-label indications for chemo-induced nausea and vomiting in advanced illness, or post-op nausea and vomiting. There's literature to support that the use of droperidol to treat CHS results in overall less use of other antiemetics and reduced hospital stays. So this is often, you'll see in many cases, extrapolated to haloperidol as well. So you'll see haloperidol used a lot for the treatment of CHS. Next, I wanted to mention benzodiazepines, specifically lorazepam, not because it's the most effective, but because it's the most commonly reported in CHS cases. So benzos are GABA agonists with antiemetic effects through inhibiting the medullary and vestibular nuclei. They have off-label indications for chemo-induced nausea and vomiting and alcohol withdrawal. And then literature suggests that the sedative and anti-anxiolytic properties of benzos have some efficacy to prevent that vomiting and pain in CHS. So that's mainly the reason why we see benzodiazepines used for the treatment of CHS. Probably less familiar to everyone is capsaicin cream for the treatment of CHS. So capsaicin binds to the TRPV1 receptor that we talked about earlier with high specificity. It counteracts that abdominal pain associated with CHS, essentially. Side effects include burning, skin irritation, and blisters at the application site. Currently, no drug interactions have been reported, and literature suggests that it is a non-systemic, cost-effective, and frequently reported as effective treatment, probably due to its warming sensation counteracting that thermal dysregulation that we talked about that's caused by increased cannabis use. Similar to capsaicin, it has been proposed that hot bathing may act by correcting the cannabis-induced disequilibrium of thermoregulatory systems of the hypothalamus. So again, working on the thermoregulatory system. So you'll often see patients who have been diagnosed with CHS have this compulsive obsession with hot showers or hot bathing. That's what's mainly reported. Less reported are things like saunas or hot tubs. We mainly see these hot showers, probably because they're most accessible. But you'll often see this compulsive obsession with self-treating by taking these hot showers, but prior to coming to the hospital when symptoms become unmanageable. I wanted to emphasize that this was by no means a comprehensive list of treatment options. There have also been reports of other medications such as olanzapine or even dronabinol being effective in these patients. But these are the ones that I included are the ones that we see most often in the literature as being used. That brings us to our next question. That was a lot of information, but here's a tiny little piece. Bucky Badger presents to the UW Health ED with symptoms of nausea, vomiting, and dehydration. The patient has no past medical history of migraines or mental health issues, but has been using marijuana daily for the past 15 years. Choose the appropriate course of action for this patient. I think I saw a B pop into the chat, and that is correct. While pharmacologic symptom management is one of the many talents of a pharmacist, I think advocating for and helping with collecting these robust histories from patients is the first step to this excellent patient care that we like to provide here at UW, especially in cases of CHS, because it's most often misdiagnosed. So if this is something that, you have a hunch that a patient could be using cannabis and their symptoms could be due to it, this is something that you can really advocate for every patient, but especially for these patients. This brings us to our next section of transitions of care, something else that pharmacists are widely involved in here at UW. The appropriate transitions of care, I think, is essential for our CHS patients. And this includes establishing primary care follow-up, along with social support, substance misuse counseling access, like we talked about before, like abstinence, and reflection strategies and education. This can all really help promote abstinence and prevent readmissions or recurrence of symptoms. A UW resource that can be utilized is the UW Health Behavioral Health and Recovery Clinic. It's a great resource that we have here at UW, but if you're at any other institution or maybe a patient doesn't want to be seen in a clinic, they can also be educated on the SAM HSA National Helpline that we talked about before. The downside to this one is that it's only offered in English and Spanish. So patients who have a different native language or prefer a different language, it might be more beneficial to find more local resources that do have interpreter services, so they have access to that. But again, this resource is free, it's confidential, it's available 24/7, 365 days per year. So knowing this, question 3 pops up quite quickly. Which of the following is the appropriate step to facilitate transitions of care for a patient hospitalized with CHS? Seeing Margaret put in C. And Joe. Woo. So that's the correct answer. The healthcare team as a whole, I think, can best serve a patient with CHS by tackling the root cause, which is the key, which in this case is the excessive cannabis use. So supporting the patient and setting up access to a substance abuse counselor, I think, is pertinent to maintaining symptom-free. So what does the literature say about what we've talked about so far? I've alluded to it a lot, but it will probably come as no surprise to you all that not many robust studies have been done with CHS patients. Much of the literature published is case reports or series or systematic reviews of these reports. We'll look at two of them. So Richards et al. Published a systematic review that included 63 articles, including retrospective studies, case series, and case reports, with the objective to review evidence for pharmacologic treatment of CHS. This study included 4 prospective studies, 3 retrospective studies, 12 case reports, and 12 case series, and 44 case reports, with case reports being the lowest grade of evidence and prospective studies being the highest grade of evidence. So these articles, the grades that I mentioned, were graded using the Oxford Center for Evidence-Based Medicine levels of evidence. Reportedly by this case, or by this report, a large variety of treatments were mentioned in these articles. The higher grade articles found that showers and baths were universally effective. High quality of evidence for pharmacologic treatments of CHS, however, was pretty limited in all the articles that were surveyed. Benzodiazepines, haloperidol, and capsaicin were the most frequently reported as effective acute treatment for CHS, according to this report. So overall, the authors concluded that hot showers and bathing, as well as benzos, haloperidol, and capsaicin are likely effective treatments for CHS, which is why I mentioned all of those before when we were talking about treatment options. In 2022, pharmacists at the University of Michigan published a review that summarized the management of CHS, but they focused on the treatment using capsaicin. So they attempted to combine the data published from various case reports and series to estimate the response rate for various therapies. A total of 9 case reports and 2 retrospective cohort analyses were included in this report. And essentially they found that data to support the use of topical capsaicin to date are of really low quality and are limited to case reports and series, as well as the 2 retrospective studies that they included. Other limitations that they found were that definitions of response reported are generally not specified and are really inconsistent between the reports that they included in the assessment of efficacy was also a limitation because with topical capsaicin, the assessment of efficacy was often confounded by concurrent administration of other antiemetic agents or multiple other treatments. In addition, capsaicin regimens were not standardized, and that's to be expected, I think, with the variety of concentrations, the cream quantities that can be used, and the application techniques used as well. So this report concluded that there's really no high quality evidence for the use of capsaicin, but its efficacy is highly reported in case reports and series. So overall, both pieces of literature essentially alluded to the fact that as the prevalence of CHS increases, future prospective trials are probably needed to evaluate and further define optimal pharmacologic treatment of patients with CHS, because really no standard it has been reported. There are some treatments used more than others, but which one to use and which one is better than the other really is subjective and hasn't been studied. So as an appy and a new resident, I've seen CHS a handful of times, but I've chosen to present a published case to help us visualize what a typical course for a CHS patient might be. This patient is a 33-year-old male with a history of PTSD, hypertension, GERD, and cyclic vomiting syndrome. So that's something to note. His medications at home or prior to admission medications are citalopram and omeprazole. Social history includes intermittent recreational marijuana use, a previous tobacco user, and previous alcohol user, so just 2 beers daily. And he really presented to our ED with severe nausea or their ED, I should say, severe nausea and intractable vomiting up to 6 times an hour, 2 times a day with no precipitating factor, so no cause for it that he could identify. He endorsed nausea and vomiting, abdominal pain, lightheadedness secondary to dehydration, but denied any fevers, changes in bowel movements, or sick contacts. Upon an interview of the patient, they found out that in the past 2 years, the patient has had similar episodes resulting in 5 previous hospitalizations, consisting of extensive workup, which was largely negative, and he ended up being diagnosed with cyclic vomiting syndrome. He also mentioned that his marijuana use has increased from intermittent to daily over the past 2 years because he has been experiencing this increase in pressure. The patient also mentioned that he's been experiencing this compulsive pattern of bathing at maximum temperature to relieve this nausea. He said that this was really the only thing that helped him. No medications were really working for him. Both physical and lab findings were relatively benign, as you can see here. And then during the final admission that the case report was based off of, his diagnosis was changed from cyclic vomiting syndrome to CHS because of that key piece of information that he provided of him going from intermittent use of marijuana to daily use of marijuana, and his symptom relief with that hot bathing. So at that admission, he was treated with IV fluids, IV ondansetron, and then his prior to admission of omeprazole was continued. They did mention that despite counseling, the patient was not willing to stop using cannabis, and he was discharged home with education to follow up with his PCP, but the compliance with that follow-up was not reported. So here, I think it's important that we don't know, what type of counseling was provided to the patient that made him unwilling to quit cannabis, and that could be that maybe the patient just wasn't ready, and we don't know if he followed up with his PCP, so we don't know if he had any recurrent symptoms because he wasn't willing to start with his cannabis. And I think this case is probably a very typical case of patients who present with CHS, because oftentimes they are lost to follow up. We don't really know what the ultimate outcome is for the patient. I think the takeaway that I wanted to share from this case is that the importance of collecting a robust social history when a patient is first admitted with the presentation of that. I guess the takeaway is that collecting that robust social history when the patient is first admitted with a presentation that can be interpreted with severe or several different diagnoses is really important so that the correct diagnosis can be made, which was something that was lacking in this. So, that's something. I wanted to end this presentation by touching on public health. I think this is something that's incredibly important. It's very near and dear to my heart, and I think that the public health implications of cannabis use and misuse are important to understand, especially as we see a rise in CHS cases. With many states legalizing the use of both medical and non-medical marijuana, and increasingly favorable public opinion emphasizing the benefits of marijuana emerging, I think it's reasonable for us to expect that marijuana use will become more frequent and widespread and will likely spread to Wisconsin, even more than it already has. And while legalization often makes headlines in the news, on social media, there are also those who support the criminalization of those who use or are in possession of cannabis. Our job as healthcare professionals is to leave our own biases out of treatment of our patients with CHS. So despite what your stance is on the matter, treating a patient as a patient and not bringing in your own biases, I think is really important in these patients, particularly. So we know that marijuana is widely thought to be a powerful antiemetic. We see medical marijuana be used in a lot of disease states. Specifically, oncology patients may be advised to use cannabinoids to relieve chemotherapy-induced nausea and vomiting, only to develop CHS over time. The belief in marijuana as a therapeutic and benign agent, essentially, is so pervasive among some patients and certain healthcare personnel that they often persist in using the cannabinoids, even if they're educated about the role of marijuana as a potential pro-emetic, like we talked about. In some case reports that I saw in the literature, a few patients even rejected the notion that marijuana might in some way be causing their symptoms and refused to give it up, even if they were educated that it might relieve their symptoms. So I think this is something really important to keep in mind as well. So I believe that the biggest takeaway here is that there are a lot of moving parts to consider regarding public health when we are talking about cannabis use and the increasing prevalence of CHS. This is especially tricky since cannabis is both an illicit drug at times and a legitimate medical treatment. So regardless, again, of what our stance is, as healthcare providers, it is our job to treat each patient as they are, objectively and with evidence-based, or in this case, as evidence-based as possible, medicine. And as we like to say here at UW Health, it's our job to provide that remarkable healthcare. And so treating each patient as they are should be the focus of our job each and every day. So since we have a little bit of time left over, I wanted to know if anybody wants to unmute, what you all think the implications of CHS might have on public health, or if not that, if you've come across this diagnosis in any patient that you've cared for and what their care looked like here at UW. So if anybody has any thoughts or any discussion points, I'd love to hear them.
Shivani, this is Victoria. So I'm not sure if this is really like a public health implication, but based on my little experience, I have not seen CHS. So I feel like maybe it's just not very well, like people aren't as aware of it in terms of differential diagnoses. So it could be leading to like poor use of resources when working patients up if there's a lack of awareness about it. So like just increased awareness would be useful.
Yeah, I totally agree. And I think that's a huge theme that I saw as I was doing my research is that many people haven't seen this. And the entire time I was thinking maybe that's because, you know, they weren't collecting those histories, or maybe they just didn't know about it. They didn't know that this was a thing because, again, like it hasn't been reported on too much. And then they use, like you said, all these resources to try to help these patients, but you know, nothing really works out. So I totally agree. Thanks, Vicki. I think Joe said something in the chat, but I can't see it. Hey, Ellie, can you see what Joe said in the chat?
Yeah, Joe said saw a patient with likely CHS, but wasn't even on the differential when they presented.
Was that something that was talked about later on, Joe? Maybe towards the end of the admission at all?
Hey, Shivani. Unfortunately, I didn't follow the patient long enough to see their like admission start to finish. So I'm not sure, but just to kind of echo what Victoria had brought up too, it kind of sounded like a similar situation where it wasn't even necessarily like a top of mind thought. Not to say that, you know, other things could have been going on too, but yeah.
Yeah, definitely. Thanks, Joe, for sharing. So I hope that this presentation at least puts it on our minds. So as we are involved in these care teams, we can maybe present this as an option, as a differential diagnosis, if we think that maybe it could be the cause of this patient's symptoms. So thank you, everyone, for sharing. I appreciate that. With that, I just wanted to conclude with the differential diagnosis can be difficult. Patient and provider education in this area or patient and provider education for CHS is an area of growth. And definitely more studies are needed to establish appropriate treatment algorithms. And really, I think where pharmacists can play a huge role is the transitions of care for these patients and how it should be prioritized. With that, I want to thank my fabulous content expert, Liz. I really appreciated all your help and guidance throughout the process of creating the presentation. And I will take any questions that anybody has.